Hi, everybody. So my name is Cameron Arani. I'm an operating room nurse at Sick Kids. I've been one for about 5-ish years now. I'm also a nurse informatician at Sick Kids, and I am co-chair of our perioperative care unit's greening committee. I am one of the many individuals who helped create the TASIN environmental operating room scorecard. At Sick Kids, we got our scorecard and we were very, very, very low. I don't remember how low, but we were one of the worst. So we kind of looked at it and thought, okay, now what do we do? These are very daunting. I am just a nurse. I don't know how to implement any of these initiatives all by myself. And I'm sure many of individuals felt the same way. Like even if you're a physician or a surgeon, how do I have the free time now to tackle all these different initiatives? There's so many of them. So one of the first things we realized we had to do was make a green team. So this is a little bit of why we ended up making a green team. Not one person knew everything. It was something that got brought up when I was doing the interviews. It got brought up when I brought this back to Sick Kids. You really had to get multidisciplinary components. So we had to get nurses, anesthesiologists, surgeons, attendants. We had a greening project leader, and management and leadership and quality and safety all got involved and regularly get involved with our greening committee meetings. We realized staff were very resistant to change. A lot of the recommendations in the scorecard are culturally ingrained within all the different staff members. And to change those practices, we recognized was going to take a lot of time and effort that not one singular person could do by themselves. The education alone was going to be a daunting nightmare, is what we like to call it, a nightmare of education, because you had to target each of the different groups individually if you ever wanted to do something. And then you had to do a broad education across all the different groups. So everybody was totally aware of what was going on. We also made it because we had a large outpouring of interest from all of our staff when we sent out a blanket email to everybody. We had multiple volunteers, even from outside of the operating room, that wanted to be involved in our perioperative greening committee. And the scorecard actually worked in our favor because there was the two different versions, as many of you know. One was sent to the CEOs, the other one for the clinicians. And the CEO one pressured the clinicians into making this greening committee, and it pressured our quality and safety committee to be like, yes, you need to make this now. So how we did it, like the actual steps of how we did it, it was very, very easy because of that top-down pressure that we got as well as the bottom-up pressure. We utilized the existing environmental program manager that was in our institution, not present in all institutions. Hopefully, eventually it will be. We quickly identified co-chairs from a very, very vocal anesthesiologist who had multiple ideas of things she wanted to tackle first. Then me, because of my scorecard knowledge, and we had our environmental program manager that did the rest of the hospital, but never really knew the operating room. A problem that many of you will probably face if you do try to bring in the external environmental program managers is they lack the knowledge of the environment or the operating room environment. We always call it like the vault or black box where nobody knows what's going on outside of it. Then we created terms of reference, which was tricky because greening committees across Ontario don't actually have terms of references more often than not. We felt like it was necessary for structuring our greening committee and ensuring that we had proper attendance at meetings. And then we emailed everybody. And then it became very, very tricky for me. Co-chairing one of these committees is, again, tricky. By design, you need to have frontline clinicians leading a lot of these changes because they're who's going to be impacted by the change at the end of the day. And as we all know with COVID, there's almost no time for clinicians to be attempting to lead these changes and find the time to come to monthly meetings. We had to drop down our time from 1 hour to 30 minutes recently, just so that we could get more people coming to our meetings and they seemed less daunting. The metrics was also extremely challenging, we decided, measuring and reporting back to individuals on how we were being successful. In the literature, you get told about waste audits and like life cycle analyses and measuring carbon emissions. But as a frontline staff, we didn't fully understand, and the scorecard doesn't really outline how best to conduct some of these necessary metric analysis portions. And then the prioritizing for the initiatives was confusing. So we were told, we have to make this committee, we have to work on the scorecard, but we have a budget of $0. Everything that we have to do has to be reworked within our existing budgets, or we have to find some sort of external funding. So we created a green team. We're slowly working through it. We had, I think it's around 10 initiatives that are on the scorecard plus additional strategies. And we were thinking, okay, what do we start prioritizing? What's one of the hardest things and one of the easiest things? Because we wanted to get hard things slowly rolling and then kind of get the easy things kicked out as we went. So we picked the hardest thing possible, which was biohazardous segregation. This is a chart which I find absolutely fascinating and cool. It was created by our environmental program manager. It's for hospital-wide, but is readily applicable to the operating room. What we changed was our practices surrounding what we identified to be biohazardous waste. In the past, we considered anything that touched a patient or came close to a patient to be considered biohazardous. We had been fined in the past due to incorrectly segregating waste, and they even threatened to take away our waste handling contract if we didn't accurately segregate waste again in the future, which terrified everybody to the point where we didn't want to treat, we want to just throw everything in the biohazardous waste. That caused more than $100,000 in increased costs, as well as unknown environmental waste, which was poorly segregated. So then this was created. This is the new guide that got approved from our IPAC department or OC Health department. All the different units within the hospital got approved by our OR specific IPAC, our OR specific occupational health department. And the main things from it are, I didn't keep the animations. Anything that's considered soaked in blood is biohazardous. If there's any liquid blood, that's biohazardous. If it has a biohazardous symbol on it, that is biohazardous. Everything else can go in regular waste, hazardous drugs, or pharmaceutical waste. And then we correctly segregate from there. And based on this new guideline, we produce basically no biohazardous waste. To assist in the process too, we found this through Daniels. They are hard-sided N64 bins. They have a lid and pedals, because what we found also through our research is Ontario regulation stipulates that all biohazardous waste in the patient care area needs to have a lid, and it can't be in a rippable bag. So we were kind of violating Ontario health rules that we didn't even know existed, because that's also a trend you'll find when you start implementing a lot of these initiatives. Legislature is kind of iffy on what you have to do versus what you kind of need to do. And this is one of these things which you apparently are supposed to do. So anyways, we found these bins. They ticked all the boxes. They've been proved in Daniel's own research. So not sure how trustable it is, but whatever, that they reduced waste through improved segregation. They directly reduce infection transfer because of the foot pedal. You don't actually have to open the lid. They are cost effective, they are reusable, so all the waste just gets dumped out, gets treated through either incineration, autoclave, landfill, that process, and then you get the same bins back after they wash them. They can be stacked on top of each other, so with sick kids, we have spacing issues because our hospital is so old. It makes it a little bit easier for us to store them in multiple different places, and apparently they're supposed to have time and labor reduction because you're not having to tie off all the yellow bags and dump them to another bin. When we were trying to implement these bins though, and we're currently, this is our main topic that we're trying to do, it's been very tricky because it's one of these initiatives that impacts nursing more than it impacts surgery and anesthesiology. What nurses, as operating room nurses, we have to do is count all the items that go in a patient and out of the patient. The only items with our new biohazard segregation guidelines that would go into these bins are sponges. Because we're producing so little waste now because of our new guidelines, these bins were barely getting filled up. So we didn't know what we would do, if this was economically feasible, environmentally sound. So we had to create a new policy that went against existing nursing policy, where countables could be thrown into these biohazardous bins and kept between cases. And that involved talking to our educator, our manager, getting full approval from that. And that's kind of where we currently stand. We're hopefully going to be implementing these bins officially across all of our operating rooms come beginning of November. So what else have we done or in the process of doing? The little easy fixes that we kind of were doing at the same time. So we removed desflurane from the hospital's formulary, and this might be a pediatric specific thing, but it was ridiculously easy for us to do this. It took from bringing it up to removing it from the formulary 3 days. We looked at our usage rates, which are barely anything. Our anesthesiologist met with all of their group. They said they didn't mind removing it because the only indication really was bariatric patients, and we don't have that many bariatric patients. And there's other strategies you can use that are actually safer than utilizing desflurane. So they just took it off the formulary. The next was stopcocks for all of our IV tubings. Not sure if this is again SickKids specific, but whenever we were giving patients gravity lines in our operating room, so we'd have the gravity line IV, you'd have a stopcock, and then you'd have an extension tubing. The stopcock wasn't actually ever necessary or useful because if you wanted to push medications, there were other injection ports that were just lowered down. So it was one of these situations, again, where we just messaged all the anesthesiologists, asked if they minded us removing stopcocks. They said they didn't mind. So now currently we just make IV tubing with an extension, and we're hoping to even phase out the extension tubing soon if we're deemed not necessary or not something that nurses should automatically be making. We're working to streamline our anesthetic balloons, pediatric terminology there, but the breathing bags, because what we found is at our institution, we have 500 ml bags, we have 1 liter bags, and we have 2 liter bags. And there was a miscommunication in education between our attendants and our anesthesiologists, and the attendants were assuming 2 liter bags were necessary and 500 liter bags were necessary for certain patient weights when they weren't. So our anesthesiologists now are trying to lay claim back to setting up their own machine with the balloon, and we'll be throwing out less of them because this picture that I'm currently showing is an example of 1 week's worth of balloons that we were throwing out from our institution. And these can't be recycled. They're those special rubberized balloons. Another thing that was recently brought up by one of our surgeons is how can we better streamline our custom packs? So a quick explanation for those of you who do not know what a custom pack is. It's what nursing utilizes to set up their sterile field. It comes with all the single-use disposable items that are necessary for surgery. They normally get customized to specific surgical services or surgical procedures. And they can be customized, they can be streamlined. Ours are from Medline. Medline even has a special greening initiative that you can get back to them and they'll remove things based on if you don't use them or not. But it's really, really tricky. So this picture is from, again, one of our ENT surgeons at SickKids. He took a picture of, or I think around a month of green light handle covers, the single-use disposable ones that you just get thrown out, that didn't get used. And he's trying to figure out now, okay, how do we talk to all of our nurses, all of the surgeons, coordinate which procedures we need to remove these single-use green light handles from, which ones can we keep on specific pick lists, and which ones need to have the single-use disposable as needed bagging of them. So that is all I have. I hope that shared some light on some of the things going on with the scorecard and how it can be useful within your specific institutions.